So while the slides are opening, I'll just introduce myself. My name is Dr. Ally Rooney. I'm a consultant neuropsychiatrist, and I work at the Robert Fergusson Unit, which is the national unit for brain injuries in Edinburgh. And I'll explain more about the unit in the course of this talk. But I was asked to speak about something that fitted the theme of progress and success. And I thought I would take the title Small Steps and New Horizons in Neurorehabilitation, because it is, as I hope I'll show to you, it is very much a long journey where someone needs to consider taking very small steps as they go on a long distance. So where I'm coming from on this is from my work in the Robert Fergusson Unit. I've been here for the last year and a half, and I thought I would reflect on some of the things that I've learned that I didn't know when I started working in the unit. I had trained in neuropsychiatry, but this is a very particular set of patients with their own needs, and I thought I would explain to you today a little bit about what that's like. Before I do, just to orientate, that after a brain injury, there's a great deal of heterogeneity in the type of patients that one could focus on in a talk like this. You could think about people who've been acutely brain injured or people who've had a brain injury many years ago. You could think about people who had a mild brain injury or people who had a severe injury or any mix of those conditions. And they do tend to present with different sets of clinical problems, as you'll see. People with mild brain injury who are very acute will tend to present to acute services such as A&E. If their symptoms persist, they often end up in neurological outpatients. Whereas if they've had a severe brain injury, they might go locally to the trauma services at the Royal. And if they're severe and they've had their injury some time ago, plus they have behavioural problems, challenging behaviour, then they're often a candidate for our assessment in the RFU. So today I'm going to be talking about this particular patient group, people who've had a severe brain injury and who have challenging behaviour when that happened some time ago. Now, to give you a sense of what happens in the RFU, when patients come to us, we begin a set of multidisciplinary assessments which involve an early formulation and from that a set of goals based on their needs, and that leads into treatment plans and focused interventions to help us achieve those goals. And this is a time frame of 3 months. So people come to us having had an injury some time ago, and then they begin a period of 3 months of assessment before we think what we're going to do next. They then enter a set of 3-monthly cycles with, again, goal planning, multidisciplinary input to deliver those goals and support plans to achieve them. Now, because they come to us after some time has passed, as you can see here, the brain injury happens, the acute admission, there's acute neurorehabilitation, and before they come to us, there's often an attempt to place them somewhere in a medical ward waiting for a community discharge or a discharge to the community that did fail or a care home that did fail. Because of that, they're often coming to us a year or more after their brain injury. And although we all know that most of the improvement after a severe brain injury happens in the first 1 to 2 years, that is still not a problem for us because it is the case that improvement can be seen after a brain injury for many years. And when I was looking into research for this talk, I came across this interesting recent paper illustrating that there may be different groups. I'll move this to the side so I can speak. There may be different groups of patients in their trajectory after a brain injury. So to orientate you to this graph, along the bottom there's a period of follow-up from 1 year going out to 10 years. And up the y-axis here, this is a scale of how well the person is functioning, how well they're looking after themselves. And what the authors have done is they've taken their data and they've analysed it and found that patients fall into one of 4 different groups over a 10-year period after a severe brain injury. There are people who have very poor function at 1 year and for whom that function remains poor. And there are people who have very good function at 1 year and their function remains well. But importantly, especially when you consider the potential for rehabilitation in places like the Robert Fergusson Unit, there are people who can score relatively poorly at 1 year, but who still nonetheless improve in different trajectories over a 10-year period after the brain injury. So this, I suppose, was news to me in the sense that previously one had thought the graph that we all know, where they improve fast over 1 year, a little bit more over 2 years, and then it more or less flattens off. What this graph adds is that while that may be true for some people, there are others in whom the trajectory can continue to improve. Now, there is a caveat or two to my interpretation of this. First of all, the lines are slightly misleading in terms of illustrating the trajectory of improvement, because the x-axis along the bottom is not linear. It goes 1, 2, 5, 10. So you have to imagine a 10-point x-axis for this. We also don't know the age of the group of patients in these groups, and nor do we know the extent of rehabilitation that they received. However, I think it is the case, certainly from our clinical experience in the RFU as well, that we do see improvements many years after the injury. Now, in terms of talking about small steps and new horizons, I thought I would update you on our recent initiatives in the RFU. It's a unit that's on our doorstep, and it's a national unit. And I thought, rather than describe the achievements of some faceless academic somewhere else in the world, I would talk about things that were local to us. And to consider new horizons, I've also taken a recent research project that I was involved in, and I'll explain that at the end. So, most clinical problems can be considered at multiple levels. This is taken from the research domain criteria in the National Institutes of Mental Health. You can think about a problem at the genetic level, molecular, cellular, circuitry, and so on. Now, in the RFU, we only focus on some of these: physiology, behaviour, and the environment. Thinking of our job in the RFU, it is to re-socialise people. They are patients who have not been able to function in any other setting because they're aggressive. And we do that using individual and group activities. We may devise care packages around their discharge that help them succeed. And thinking physiologically, we want to improve their cognition, their memory, executive function, and insight. Treat depression, anxiety, sleep disorders, and psychosis. And set goals according to their needs. So one of the things that we're doing in the unit is training our staff in something called the RAID approach. I don't know if any of you are familiar with this. It is an approach to managing challenging behaviour that seeks to reward appropriate behaviour and ignore, downplay, or implode disruptive behaviour. Now, that might sound like common sense to you, but it's actually quite difficult when faced with a challenging patient to avoid being authoritative and wagging the finger at them. So what we do instead in the RAID approach is we try to notice when they're behaving in a way that we want them to behave. So for instance, if they're sitting calmly, having a cup of tea, talking to other patients appropriately, we'll reward them and reinforce that behaviour. Because one of the principles of behavioural management, which is, again, deceptively simple but quite powerful, is that if you reward a behaviour, you make it more likely to happen. If you reward a behaviour, you make it more likely to happen. And what that reward can take many different forms. Some patients want to be rewarded with attention. So if they become aggressive and you reward that by getting angry at them, you're giving them the attention that they need, and you'll make the behaviour more likely to happen. So we try to frame our rewards as being rewards for behaviours which are not the target behaviour that we want to eliminate. We want to shape their behaviour more towards the way that we would like them to behave. Which means that when they're being disruptive, we seek to downplay that, distract them, implode that behaviour, not make such a big thing out of it, and place all our chips, as it were, on helping them to move towards the way that we would like them to behave. Now, that's not intuitive. It's much easier to say to a patient that's being bad or difficult, stop that, you shouldn't be doing that, go back to your room. And I think we've all, or many of us will have grown up in environments which were authoritative in that kind of sense. And therefore it involves a significant degree of staff training to do this consistently. And thanks to the efforts of our senior nursing team and our managers, we have funding to allow all our staff to train in this. And I think this is a really positive approach that we're taking now in the unit, which wasn't there before. There is a second initiative that we've just introduced, which I'm really excited about, which is something called goal attainment scaling. So this is an approach to measuring whether or not you've achieved your goals of rehabilitation. When I started in the unit, we were measuring them whether or not, had they been achieved or not, yes or no. But recently, one of our speech and language therapists introduced a different method where the goal is broken down into almost on a ladder of how much it's been achieved. Importantly, including whether it's been exceeded. And this fits very much with the RAID model of promoting behaviours that we would like to see made more consistent. The patient begins at the bottom of the ladder, and then they're given a score over time as to how well they've managed to achieve that goal. As well as providing a motivation to the patient, it allows us a simple way of quantifying how well we're managing to meet the goals. And I hope that as time passes, 4 to 5 years down the line, we'll be able to show graphs that show how well we meet the different types of goals for patients, which will in turn allow us to feed back on our processes and make changes and continue that audit cycle to make the unit function even better. So I think this is a very powerful method that I hope we are able to use widely over the next few years. I note that there are talks and workshops on art therapy and music in the next, in the rest of the day. And it is something that I've only personally realized recently, the effect of using metaphor in patients with brain injury. Now, this was something that literally, it was about last month I was talking to our art therapist and the penny dropped. No one had ever told me before, so I thought I would share it with you. The power of using metaphor specifically to bypass deficits in metacognition. Now, metacognition is our ability to think about our own thinking. So for the brain to step outside itself and reflect on its own thinking processes. And because of the effects of brain injury, that's often very difficult for patients who've had severe injuries and who have executive impairment. The example on the left of the screen is taken from the internet. It's an interesting picture of a man who has had what is clearly a left hemispheric stroke. You can see his left hand is protectively holding his right arm and the right side of his face is drooping, and therefore I assume he's struggling with language. And he's drawn himself, representing himself as the figure in this screen, where the drooping of his face is also reflected in the picture. But in our unit, our art therapist had asked some of our patients to draw a shield, and she had said to them, on the outside of the shield, around the outside, I'd like you to put the kind of things that other people might see when they look at you. And on the inside of the shield, I want you to write what's really there. And one of the patients in particular, who I think our clinical team had felt had severe deficits in metacognition and wouldn't be able to describe his own thinking, did really well with this. And I was able, reading his responses, to understand how he was thinking about himself and his place in the unit. Whereas if we just asked him face to face, it would have been extremely difficult, I think, for him to do that. Again, we've also been using metaphor in terms of reshaping someone's personal identity. Having a severe brain injury is a great challenge to your sense of identity and role. And another of our patients, we have used something called metaphoric identity mapping, which is a technique where you invite the patient to think about their hero. And in this person's case, the hero was his mum. And for the patient then to write down the values associated with that person and the kind of way that they would respond in certain situations. And when they are behaving in a difficult way, you can talk in terms of, is this how your hero would behave? How do you think your hero would respond to this? And they can understand that on an emotional level through the use of metaphor, in this case the hero, rather than having to process that they're not supposed to do a particular behaviour. So this is a very powerful approach, which I think we're using quite a lot in our unit, because many of our patients do have metacognitive or speech difficulties. Another thing that's happening this afternoon, and which is very powerful, is the use of music. We had a third patient who is very impaired, who really struggles to engage with any of our groups that we would tend to use, but who responded terrifically well to our music therapist singing Johnny Cash. And he lit up and remembered her whenever this was happening. So I learned from that music is another way to reach very impaired patients. And this isn't borne out just by our narrative experience. It's also been shown in a recent meta-analysis where the different studies are sort of compiled and statistically analysed. And you see at the bottom that there is an effect. This is in patients, I think, with dementia, where music improves functioning. In this case, executive functioning is exactly what we're looking to improve in our unit. Another angle which we're really beginning to push more is the idea of assessing people through the use of activities. We know from talking, looking at the literature and talking to patients, that when they're finding it difficult to speak and someone comes in with a big battery of tests, then later on, once they've recovered, they look back and they remember that as a difficult time because they don't like to feel as if they're being tested. So we assess people through the use of activities. We got some money to buy an all-ability bike, which allows patients with any abilities to get out and about around the ward, seen here with two of our OTs riding it. And we have recently, again through the brilliant work of our senior nursing and management team, managed to get money to employ 2 activity coordinators as well, which will really help our patients, because again the purpose of the unit is to re-socialise people. And this can take many different forms. We recently had a little bit of press notice and attention through our raising money for the Ukraine by walking 4 million steps in the unit. This was an idea that came from our patient feedback group. They said they wanted to raise money for the people of Ukraine, in this case the Red Cross. And so everybody got a step counter, and we wore the step counters for 2 or 3 weeks in March and April, and we walked a total of 4 million steps, raising over £2,500 for the Red Cross in the process. So using this patient feedback and using it to develop initiatives that can, with multidisciplinary input, is something else that we're doing in the unit. And our outreach service is something which we hope to be able to use to provide advice to clinical teams nationally. We do accept referrals from all over the country, and it's not just them coming to us. We are also prepared to go to them and to advise on how to manage difficult cases in community settings. It would be, I think in the future, I think we would like to be able to get some funding to develop this service some more. So just for the last few minutes, I'd like to let you know about a research study that we did, which I think has an interesting outcome. Now, this is the problem of fatigue in people who've had an acquired brain injury. In this case, the brain injury is a brain tumour. This is one of my other interests. And we know from systematic reviews that there's really a lack of evidence about whether treatments are effective in managing high fatigue. So what we thought we would do is ask a personal trainer to work with brain tumour patients, helping to coach them on appropriate choices of drinking, amount of rest, healthy diet, managing stress, and movement and exercise. The chap we used, this chap here is called Gary. He's a former Royal Marine and very good at motivating people. And we also asked a charity representing brain tumour patients to help them problem solve around the management of fatigue. And we combined those two things in a pilot multidisciplinary trial, taking patients from Edinburgh, Glasgow and Manchester who had a brain tumour, who were highly fatigued, and giving them either the health coaching intervention or the health coaching and the problem-solving activation coaching intervention. And we measured various outcomes. Now, interestingly, what we saw, I'll just quickly describe what this graph shows. This control group shows that over time, these three different bars, the fatigue levels were relatively similar. But in the health coaching and problem-solving group, fatigue levels were significantly lower over time. And this is one of the first demonstrations of an intervention that can actually improve fatigue in people with acquired brain injury. It's a small number of patients, and it's a preliminary study, but it is a clinically significant outcome, I think. So it's quite surprising in a way that something as simple as improved lifestyle advice and helping people understand how to navigate their fatigue can help with it. But it was a positive outcome for us to see. So in conclusion, I only have 2 conclusion points because people only ever take 1 or 2 points away from a talk. And I just wanted to introduce you to what we do in the unit and some of our recent steps of progress that we've been taking. And a sense that some of the interventions for managing symptoms may not need to be something as complicated as medication. It could be something as simple as drinking more water or helping you with your choice of diet, for instance. And these are areas that we're hoping to look at in future as we go. So I'll close there, and thank you very much for your attention.
Hello.
Hi.
Hi. Thank you for the talk. It was good. You mentioned that you did assessments at the RFU embedded in activities. I was wondering if you could just give more detail on that and how assessments work with those activities.
So, for instance, if we want to understand whether somebody has financial decision-making ability, we may ask our occupational therapy team to do some pen and paper assessments looking at their ability to calculate. But that doesn't tell us whether they're functioning in the real world. So we would ask them to go to the shops, we would escort them into Morningside, and we would monitor how they're doing with that. That also doesn't tell us how they'll function in real life once they've been discharged, but it's an example of assessing them as they go. Another example would be if they're to go out, we're needing to re-socialize some of our patients. if we're going to be able to place them in the community in supported living as opposed to a care home, then they're going to have to be able to socialise with their carers, the people who come in to help them through the day. And so we would take them out of the unit often on trips, or to they leave the unit in the minibus and they go off to, it can be places which are outside, such as the Duddingston Loch, feed the ducks, or it could be to trips such as off to the cinema or to the shops. And we are also continually assessing people as they interact with our groups in the unit. We have a great many different numbers of groups that are run by the occupational therapists and the speech and language therapists, discussing films and watching movies, talking about current affairs. We have had, in the last year and a half that I've been there, we've had events such as the RFU's Got Talent, where everybody was able to come up and show a particular skill. And these assessments are fed back in a multidisciplinary way into the case conferences that we hold every 3 months. But I think the thing that I take away from doing this is that our patients are very impaired, often when they come to us, and progress is very slow. But over time, and sometimes that can be 2 years or more, we are often able to get them functioning to a point where they can be re-socialised in a way that they weren't when they came to us, and that's essentially our job.
Thanks for that, Ali. Right, Emma?
I had a question about gender. Obviously, you're working with people whose behaviour is problematic. I know that there are more male head injury patients than female head injury patients anyway, so you'd expect to have lots of men in your unit. But do you see a difference in the presenting problematic behaviour between men and women?
Yes, I think so. We have more men in the unit, and we have more male beds. There are 4 beds that are dedicated for female use, and 16 beds that are dedicated for male use. I think the men are more likely to be physically aggressive. The ladies can also be aggressive, but it tends to be more in lashing out during personal care and interventions like that. I think our turnover is low. So I think in the time that I've been there, which is 18 months, I think I've seen 6 female patients in that time. In other words, 2 of them that were there when I arrived are still there. So my knowledge of the clinical differences is relatively limited by that. But we do have a stall here, and it's something we've got, I'll just give a shout out to the team at the back. We have a stall for the RFU, it's next to the Sabin stall, and it's staffed by 2 of our very senior, very experienced nurses who will have seen far more than I have. So if it's something that you're interested in, please ask.
Thanks for that, Ali. Anybody else? We've got a last minute. Yes, here we go.
Yeah, I just wanted to ask about, you talked a lot about the patients who are sort of using the service, but what about patients' families and friends, if you're trying to kind of re-socialise them, how much work do you do with them? And also I kind of wondered whether, it's like a closed ward, or how much patients can kind of do their own thing, if there's sort of the ability to have a bit more autonomy in their day, or if it's kind of very structured.
It's person-centred, so it really depends on the individual in question. I can think of people who are detained under the Mental Health Act for their own safety because they're very vulnerable, and they would have to leave the ward under our supervision. And I can also think of people that I've seen who have essentially been much better functioning, are not detained, and are able to come and go through most of the day. We do work a lot with patients' families and carers. And I think that's something that continues after their discharge. So perhaps something that I could draw out here is that when the Robert Fergusson Unit discharges a patient, it's not the end of our involvement with them, unlike a lot of other NHS services. We have, through our outreach service, we will stay involved with the patient's family for as long as necessary. Now, sometimes that can simply be a matter of weeks, and then they would go back into the community and follow up through the neuropsychiatry outpatient clinic. But sometimes it can go on for much longer, and I know Lorna, who's also sitting at the back, has been involved with a patient and their family for years after they were discharged. So it really depends on the individual's needs.